Good noontime, and welcome to our child and adolescent psychiatry grand rounds and clinical conferences. I have been assured that the equipment in all 4 sites should be working now, so it's a pleasure to welcome all of you in your various sites. Today we have an unusual opportunity to hear about a very important and critical piece of the child and adolescent psychiatry programs in our city. I have a special interest in this because when I finished my child fellowship here in 1970, I was the first trained child psychiatrist to be employed at San Francisco Juvenile Court. And so today I wanted to introduce Dr. Rody, who is the current medical director for special programs for youth at the Youth Guidance Center. Dr. Rody comes to us from largely an East Coast training, University of Pennsylvania undergraduate, Temple University, Philadelphia MD, and kind of an unusual and special adult and child psychiatry program from Georgetown University in Washington, D.C. She came to San Francisco and since 2003 has been with the San Francisco Community Mental Health, first as at the Mission Family Center, and in the last 2 years at the Special Programs for Youth at the Youth Guidance Center. She will introduce her associate in this presentation.
Thank you. Yes, and my title is not, as the email announced, Medical Director for the City and County of San Francisco. I find it quite enough to be behavioral health medical special programs for youth. Thank you. And this is
Use the microphone.
our behavioral health director, Mona Tahsini, who, thank heaven, has been in the facility and the organization a lot longer than I have. She started when she was 10, and you've been there for what?
10 years.
Yeah. So, it's like, but she knows a lot about this very complex system in which we work. So, the mission of Special Programs for Youth is to provide and coordinate comprehensive behavioral and mental health services for the youth that we serve. We have a multidisciplinary team of medical and behavioral health clinicians, including dental care. We coordinate visual care for the youth, and really, this may be the first and best opportunity that many youth in our charge have had in a long time to us.
Okay, so I'm going to talk a little bit about the actual services that we provide there. As Dr. Rody mentioned, we are a collaborative program. We are a DPH program. We're called Special Programs for Youth. We are embedded right there in Juvenile Hall. We have a medical clinic. And so, unlike some of our neighboring counties, we have medical, dental, behavioral health, health education services all embedded in one program. And so it's nice. It's very collaborative. We're all in one unit together. So on the medical side of the house, we have nursing staff available 24/7. At admission, when you get brought into custody, they are brought in by the police, and a nurse has to triage them at the front door to make sure that they are healthy and stable enough to be admitted to juvenile hall. In addition to that, the nurses they do all the medication pass on the units for the youth, respond to any kind of medical emergencies. Youth are able to call and ask for a nurse, ask the detention staff to call a nurse, and if they're needing anything, they're there to follow up as well. to any kind of medical concerns that they have. In terms of our medical and dental services, we have nurse practitioners, and every youth that comes into custody meets with a nurse practitioner for a physical exam. We use the opportunity that while they're in custody to catch them up on a lot of their immunizations and get them connected to any other kind of medical services that they need. We work with SF General for any kind of specialty services that youth might need while they're in custody, and do a lot of coordinating for them out in the community when they're getting ready to transition out. Lots of different family planning, STI testing for every youth that comes into custody, as well as family planning. Kids can get IUDs, implants, the shot while they're in custody, so we do a lot of that as well. In terms of our behavioral health services, our behavioral health team is made up of MFTs, social workers, psychiatrists, clinical psychologists. We have services on site 12 hours a day, 7 days a week, and there's always an on-call psychiatrist available to juvenile hall after hours. So within the first 72 hours, each youth that comes into custody will meet with a behavioral health clinician for a comprehensive psychosocial assessment. And they could, even if they've been there 10 times, we're still going to meet with them again. And we utilize Avatar, which is the behavioral health electronic health record here in San Francisco. And so we have access to any kind of behavioral health records. We connect with any providers that they have out in the community. And each unit at Juvenile Hall has a clinician, a behavioral health clinician assigned to it, and so that youth becomes part of that clinician's caseload. And it really, the length of stay is very bimodal, so you have some kids that are there for 7 days, not even 7 days, and you have some kids that are often there, could be there for up to like 3 years, depending on the nature of their charge. So depending on, it's very individualized in terms of the actual treatment they get while they're in custody. But a lot of it, as you can imagine, it's very stressful for youth when they're in custody, so a lot of it is just managing some of the stressors while they're there. And in terms of just, treatment modalities, a lot of it is very cognitive behavioral therapy, insight-oriented therapy. It just really kind of depends on what's going on for the kiddo. We do a lot of different groups on the units, utilizing some of the evidence-based practices targeted for this population. We use aggression replacement training, which has 3 different components. One around moral reasoning, one around skill streaming, so just building basic social skills, and one around anger management, anger control. Again, because the length of stay is variable, we don't entirely follow like the fidelity of the model, but we use components of it, we modify it to make it work. Seeking Safety, which is a curriculum, another evidence-based practice around PTSD and substance abuse, kind of the link between those two, as well as Girls Circle and Boys Council, which is another evidence-based practice, gender-specific curriculum for youth. We do quite a bit of suicide prevention planning and management for youth in custody. We have a pretty extensive suicide plan that we'll develop with youth, suicide prevention plan that we'll develop with youth. We, have, I don't know if you guys are familiar, but there's very limited adolescent psychiatric units here in San Francisco, and so it's very youth that in the community would be appropriate for a 5150 hospitalization. We often cannot get those kids out. We can't find them a bed. And so we end up being the people that are kind of tasked with managing that. I think that, it's difficult, but in a lot of ways we're able to provide pretty good support around that. We have the ability to put youth on constant watch where detention staff are watching them constantly. We use the Ferguson gowns. So we do a lot of that for our youth, and just a lot of just support around managing crises. And they also have the opportunity, all youth are oriented to services when they come in, and so they have the opportunity to page, which is interesting, trying to explain the concept of a pager to kids these days because they have no idea, but they are oriented on how they can ask the detention staff to page us. And the crisis could be they're mad because they got room time, or it could be some, where they've actually made a more serious suicide attempt. We do quite a bit of coordination with the Juvenile Probation Department. We meet collaboratively every week for a multidisciplinary team meeting. Any youth that is being recommended by the probation department or the courts to be put in out-of-home placement, we participate in a multidisciplinary team meeting where we as behavioral health make recommendations in terms of their treatment needs. So we don't make recommendations about where they should go in terms of placement, but we make recommendations in terms of they would benefit from substance abuse treatment, et cetera. And just a lot of collaboration with HSA, with the school district, with some of the outside community providers, and helping kind of coordinate services. Often, unfortunately, juvenile hall serves as kind of an entryway into the mental health system for a lot of our youth, and so we end up really working to, while we're not going to be their long-term provider, we work to really set them up so when they return back to the community, they have the services they need to be successful.
Right, so it's unfortunate that we can be an entryway into mental health services. We see many kids who obviously have had diagnosable disorders for some years before they get to us, and our focus is on trying to get them appropriate services, and we feel that if we get somebody doing better in the mental health department, then they may not be back and may well not turn into an adult offender. So it's an opportunity that we have. It's been said that 75% of kids involved in juvenile justice services have a diagnosable mental disorder. That is from the 2005, now officially defunct, I guess, AACAP practice parameter for assessment and treatment of children and youth with juvenile justice involvement. So there are quite a lot of kids who need our services. The behavioral health staff that Mona was talking about do a great job in when they do their comprehensive initial assessment, identifying kids that should be referred for psychiatric evaluation. Not all kids are. Many are not. Many don't reach that level. They may have some mild distress, mainly around just the fact that they are in juvenile hall, but others clearly have PTSD or we'll talk more about the specific conditions later that they usually have. So they do a referral to me, and I see those kids for psychiatric evaluations and begin treatment as indicated. Also, there are some youth who come in already on medications, and if we document that there has been ongoing medication that's effective, then that can be continued while they're with us. We are clear that we're providing clinical services. We don't do forensic evaluations of youth in the juvenile, in the special programs for youth setting, but we do coordinate with others who are doing more forensically oriented evaluations, such as court orders, psychological testing, and there also is something called wellness court that has been initiated with the judges who work in the Youth Guidance Center, and I attend once a week, usually when there are kids who've been identified who have special mental health needs where regular court will be more stressful, and there's an opportunity before court even starts for myself and other clinicians involved in the case, also from AIM Higher, which is our outpatient continued treatment arm, come in and talk, and other providers from the community involved with the kids so that the judges are informed and can make the best treatment and placement decisions.
Okay, so just a little bit about, who we're serving here in San Francisco. So these are the statistics from last year. We predominantly have a male population. Our girls' population tends to be smaller.
I can't quite see that.
Yeah.
Sorry.
Sorry.
To make it
I should have
bigger.
brought my opera glasses.
Sorry.
So
You can't make it any bigger, sorry.
I'm sorry about that.
It's about 27% female and 73% male there. And that's typical. We actually have 3 male units with different ages and severity of behaviors, and then 1 girls unit.
I just want to clarify, the numbers, the counts are not, that's not at any given time, that's throughout the entire
That's a year.
That's the
correct?
year, and
Okay.
it's also duplicated detentions.
Uh-huh.
Yeah.
Okay, so.
Yeah. So, and, we here in San Francisco have actually, compared to our neighboring counties, which makes sense, San Francisco 7 by 7, San Francisco County versus like Alameda County, which is, much bigger. So we have a very small population, and you'll see in, well, you won't be able to see, some of you won't be able to see, but you'll see in one of the later slides that like our population has significantly declined. Even, I've been there 10 years, there was like 150 kids in custody on any given day, and over the summer we had some days where there was 29 kids. So the population has significantly declined. In terms of demographics, similar to across the country, large portion of our population, almost 54% is African American. The other largest population, in terms of race, is Latino youth. I think, again, as the demographics of San Francisco have changed, we've seen a little bit of variance in some of the different, ethnicities and races that we're seeing in custody.
So you said, I'm sorry, the percentage African American was,
It's about 54%.
and
And
much
the-
less
the-
Latino was,
The next, I guess, largest population would be Latino, and it's about 27%.
This is all for
Maybe you could just read those off since they're so hard for us to see.
Sure. So African American, about 53%. Asian Indian, 0.13%. Chinese, almost 2%. Filipino, 0.94%. Latino, 27%. Other is about 3%, which annoys me that they just like, if you come in and you don't look Asian, Black, or a Latino, they put you as other, even though like the system, the JJS system they have, but that's my own little rant. But that's, this is done at, these demographics are juvenile probation demographics, so at the front door, kind of how they classify you. Other Asian is about 1%, Pacific Islander, 0.67%, Samoan, about 3%, Vietnamese, 0.81%, and then white, about 8%. And so then in terms of age that we see, I think the largest kind of age group that you see is around the 16, 17-year-old age. We will have 18-year-olds in custody, and there's a couple of reasons why 18-year-olds will be in custody. One is that they're still on active juvenile probation, and so they can be housed at juvenile hall. Other times too, if we have youth that are in custody for a really long time and they turn 18 and still have a juvenile case, they will remain in custody at juvenile hall. But because of licensing, after like the day before their 19th birthday, they need to be out of custody at juvenile hall. And a lot of times, even youth that have what is kind of an adult charge, an adult case, they will house them even after they turn 18 at juvenile hall. A lot of times, just so that way they can get their high school diploma and even though they're 18, they're still would benefit from some of the services and resources available to them there. We do, from time to time, get a really young 11-year-old or somebody really young. I think that as a system, they work really hard to get those kids out of custody as fast as they can. But I would say like kind of the average age is 16, 17. And so this one shows from about 2012 to 2016 the decline. And so in 2012 there was 937 admissions. And in 2016 we had 753. So there's about almost 20% decrease. The average daily population in 2012 was 74, and in 2016 it was 45. And then the average length of stay in 2012 was 24, and in 2016 it was 20. And again, the average length of stay is very like bimodal in the sense that you have some kids that are in and out, and then you have some kids that could be there up to 3 years, depending on their case, their legal case. I will say, I think that, you know, in my time there, I think that I think that the length of stay has decreased, and, you know, as a system, we work a lot harder to make sure kids get out and we resolve their legal case sooner than later.
Okay, so we may be familiar with the percentages, certainly of various disorders and populations, but also within juvenile justice involved youth. Depression, dysthymia ranges between 15 and 30%. I'm reading these numbers because we don't have actual stats for diagnoses of the youth that we see. Maybe a good project for a fellow if somebody wants to join. ADHD, 15 to 30%, bipolar disorder, 3 to 7%, PTSD, 11 to 32%. So these, as well as conduct disorder and substance use disorder, certainly are overrepresented in our population at juvenile hall compared to kids who are not involved with the juvenile justice system.
So conduct disorder is how common?
I don't have a number on it
Okay.
exactly, but it's reasonably high.
And oppositional defiant, of course, right, also, right?
Well,
Must be
yes.
there, right?
Yes. But I think impressively some of the others that are maybe less obviously related to being involved with juvenile justice, PTSD, for example, many of the kids that we see, you know, you probably have a suggestion from the demographic slides that we showed, come from communities where there's a lot of exposure to community violence, generally early losses, difficulties, you know, in their family situation, so domestic violence, etc. So there's a very high.
That was, I don't know if that was the first time in this half hour that I've heard the word family. As a child psychiatrist, of course, you've done many family assessments. It may be difficult to do a family assessment at juvenile hall. Does it happen? Is it part of the assessment, or?
Yes, we always try to do that, and yeah, I mean, I read studies about the percent, for example, of children of incarcerated adults, you know, percent of incarcerated adults who have kids, who leave kids behind. I haven't quite seen them of the percent of kids who have incarcerated parents, but that does happen. But you know, that's something that we see a lot. The parents, I'll be happy to talk later. Maybe we should get through the slides and then we can talk more about you know, what we see. But what I find is it can be more difficult to engage parents than in other settings where I've worked. There's a certain amount of fatigue of the parents. That, you know, many of them are not involved for various reasons. We do have kids who are in custody of the state, certainly because of unfortunate events in their lives. But when you can reach parents, they often are, you know, are tired from the number of providers that they've interacted with throughout their parenthood, and more difficult to engage. But we do make every attempt that we can. depression, OCD, generalized anxiety disorder. These are things that we see, because kids with these conditions can gravitate toward negative behaviors, toward, they may have had early losses in their lives. Very often they have, and they gravitate toward maybe a gang situation as a replacement for attachments that they don't have in their lives. These are things that bring them into our awareness and our orbit. Bipolar and DDMD, of course, can involve flamboyant and socially unacceptable behaviors that can lead to admission to juvenile hall. Can we get this one to go up, or is it permanently? Okay, it's not quite formatted on. So ADHD, of course, with poor impulse control, and just plain ADHD behaviors of hyperactivity can be less acceptable in some settings, such as school settings. So poor impulse control when it comes to displays of anger certainly can underlie the behaviors that get kids into juvenile hall. So, and again, ODD and conduct disorder, of course. So we are very vigilant for these diagnoses in the kids that we see, and they can certainly underlie a lot of more things that probably have paths for behavioral issues, oppositional conduct, voluntary negative behaviors over the years. There often are real pathology underlying that we try to diagnose and treat. We're going to talk about special considerations for psychotherapy.
Yeah, so, again, in terms of some of the behavioral health, treatment and services that we do, it can be challenging because we never know, we don't have any control over somebody's length of stay. So in terms of like the actual therapeutic work, it can be hard to kind of get into it and then, end it abruptly. Specifically around some of the trauma we do, our clinicians are all trained in trauma-focused CBT. The challenge with that is, we do a lot of the psycho-ed, the prac skills, but actually getting into the narrative and, really kind of bringing these things up can be really difficult in that setting for a lot of reasons. The person that, caused this trauma might be housed in a unit next door to you that you have to walk by every day to go to school. It's really hard to bring up all these things, and then you're like done with your session and they have to go back to their room and be in there. We call it a room, but it's essentially a cell, and so it can be challenging. In addition to whatever trauma, past experiences they have, they're going through a traumatic legal case, which can be very triggering, and so it can be hard to really target treatment with some of these things, or you're working on something and you're making progress, and then this happens in terms of their legal case, or they get news about something that happened in the community, and so it kind of derails what you're working on, and so it's just something that you have to be very mindful of, and then also just the forensic nature of it. Everything that we do is not, kids know that it's not for forensic use, but records get subpoenaed. And so, having kids write about things and such is not always in their benefit. And so, again, it's using some of these evidence-based practices and, having to kind of modify them for the setting. We do also do, in terms of just some of the behavioral issues, a lot of our job ends up being doing a lot of collateral work with the detention staff, who, in a sense, are kind of the parents, the custodians of the youth while they're in custody. And, similar to a lot of families and a lot of parents, they may not have the understanding of the youth's, behavioral health needs and what works, what doesn't work. So we spend a lot of time actually doing that, where it's no, he's not an a-hole, but he actually, when you shout out 7 directions at him at once, he can't do that, so we do a lot of work with the detention staff and helping them kind of understand how to support youth in the milieu, how to manage their behavior, and it's always this balance of like, we're not going to disclose their protected health information, so it's a lot of like describing behaviors versus actually giving them, diagnostic information. And I think that, in my time there, we've developed a really strong partnership with probation, where I think they look at us as a resource. They really want our support in managing youth in custody and working really collaboratively in the milieu. So we do a lot of groups, and a lot of groups that aren't evidence-based practices, but like we're going to do a cooking project, we're going to do a just something, just really experiential activities that the kids love. It gives them a chance to engage with each other in a very pro-social way. It's really great to see kids. They tend to have, probably like in high school or any other adolescent setting, they have their little cliques, and so it's really nice to see them all kind of come together and engage with kids that they never would interact with before. We do a lot of partnership with San Francisco Unified School District is the on-site school services, and they do a great job. They do IEPs for youth that are in custody. They provide all the services that they would get within the community. And so doing a lot of work with their teachers, doing same thing. We do a lot of like behavioral plans for detention staff and for the school staff on how to work with different things. We do, from time to time get kids that, it's kind of they're having their first starting to show psychotic symptoms. We have that age group, so we often get kids that are starting to demonstrate some of those symptoms, and so that can be challenging, but it's also an opportunity to kind of get them linked up to the services that they need. In terms of parents and family, we have really made an effort to really try to engage parents more. All the clinicians, after their initial assessment, they contact parents. We are trying more and more to engage parents in that, in what's going on with youth while they're in custody, and letting them know what's going on. We try to meet with them outside of, they are allowed to come for visiting. We try to meet with them outside of that. Again, part of the challenge, I think there's some resistance. Again, they're not asking for their kid to be up there. They're not welcoming these services. And so there's a little bit of a resistance and mistrust, and we kind of get lumped into, being part of probation and being part of the larger system. And so that can be a challenge. Even when you call, the phone number comes up the same, and so I'm always like, it's not the probation officer. So because there's a little bit of resistance around that. Yeah.
Have you noticed greater resistance from certain populations, like certain
ethnicities and such? Yeah, absolutely. Because I think in certain races, certain cultures, there's not a lot of and I think just mental health, right? As a whole, there's a stigma around mental health, and so absolutely, I think that certain groups, certain ethnicities, there's definitely a mistrust of that system, and like you're just trying to put a label on my kid, or you're just trying to put them on meds, or so absolutely, yeah.
To sort of piggyback on Victoria's question, so is obviously sensitivities related to ethnicity. Marina and I are working on a project having to do with juvenile justice and sexual minorities.
Mm-hmm.
Quite a few, probably like a fifth, that identify in some respect as LGBT.
Mm-hmm.
I'm wondering if there's, put out the broadly, what your experience has been working with kids who are out, and
Mm-hmm.
and especially those who are non-gender conforming.
Yeah, I think that there's like progress being made. I think again, it's an institution, it's a jail. I think that and you're dealing with adolescents, right? So I think that those kids get often targeted, not just by youth, but even like certain, staff that have like opinions or agendas about that. So I think we've made progress in terms of the institution. I think they're making more of an effort to do more education, more training with staff. We've had some youth that have been able to be housed on other units based on what gender they identify as, but it's still not like a clear policy, right? And so it's a very great, you know, we don't dictate that, we make recommendations, but in terms of like juvenile probation, there's not a clear policy, and so it kind of feels like, okay, well, you do it this time, but you're not doing, you know, what's the criteria, what's the, you know, how are we going to manage this? You know, and I think that they're working with their staff on doing a lot more training and education. I think that, you know, some, you know, when they do searches, it's like gender to, you know, like a woman staff would do the search on a female youth, right? And so I think their staff isn't comfortable doing, you know, some of that and just uncertain about what to do. So I think that they're making kind of strides towards that, but there's still a lot of things that need to happen. But I think, but yeah, I mean, I think it's always a challenge for those youth in custody, and making sure they feel safe, they feel supported, not just not from the youth, not just the youth, but also like in terms of the culture of the entire institution.
So, as far as conduct disorder, disruptive behavior disorders, opposition to fighting disorder, of course, generally kids benefit, you know, from appropriate structure, praise, rewards, and my suspicion is that many of the parents basically have very limited resources and very little guidance, you know, that would perhaps help them address problem behaviors going forward, or perhaps preemptively to avoid incarceration. So I don't know if anyone's tracking what really works, or if anyone has developed outcome measures, you know, where communities that you already know are at risk. You know, you've probably got a few families that you know that have, you know, more than one cousin that somehow are at risk, to offer them that. So my hunch is...
So I told you should have read it. We have...
There are many systems that have failed. So I think there's a lack of parental support. Arne Duncan, Obama's education secretary, of course, is famous for his school-to-prison pipeline quote. I don't know if you've tracked which schools these kids come from, because I know there's some schools that probably have more,
Yeah.
and some that have much less.
So in terms of tracking,
Yeah.
I mean, I could, like, off the top of my head, tell you. But there is, so we do in terms of like family-specific services, we have not us as SPY, but our partners, you know, where youth are referred when they leave custody. Like, we provide all the services for in-house. We have like a sister program, Aim Higher, that does all the linkage to the community, community-based programs. So we have wraparound services. There's very specific family therapy services that are like portable services in the community working with families.
Substance abuse track and very comprehensive services.
My hunch is a lot of the kids probably have no or inadequate access to role models, adult role models. And my hunch is that it's going to be really hard to recruit volunteers. You know, like, who is ready to volunteer as a big brother for someone who just doesn't have an adult role model? I don't know if you can comment on that.
I mean, I think there is a tremendous amount of, I mean, I think here in San Francisco we have, you know, pretty good resources and services and a lot of community-based organizations that are in the communities or from the communities. So I think the challenge is I think that the needs of a lot of our youth is beyond a big brother. You know, it's multi-generational trauma, multi-generational substance abuse, you know, so I think it's, while a big brother is great, we have mentors, we have that, but I think it's a little bit, unfortunately, deeper than, you know, a big brother, what a big brother can necessarily do.
So one of the things I was going to say, I'm thinking about the family engagement piece and what opportunity there is while they're in custody. And one of the things that we did in Rhode Island, and that I'm just wondering if you've done anything like this. I couldn't find any literature, I mean, I may have talked about it, something I can't remember, but was to actually hold parent groups at the site. And we thought for sure, they're not going to show up, you know, because everything is so centered on the child, right? And this was a space for the parents to come together and build community. And we did it around the visiting hours, right? So and we had coffee and we had some stuff, and they showed up. And they started to build this community. And then we were really stuck because we thought, uh-oh, we don't have a curriculum. You know, we were just trying to think of what we do. So I think it's kind of an opportunity, actually, to build community among the parents, which we don't often think about while they're in custody. We think about it, you know, on the community side within providing institution. But have you guys done any kind of, like, group parent
We
events like that?
haven't. We've thought about that, and it's something that, like, with Aim Higher, who does more of the community-based services, the linkage to that, we've thought about doing. I know, like, the probation side of the house has done it, and you know, it's
they're
a
already
different
out in the community
right,
at
and
that
it's
point.
a different audience.
It's
you know,
a different audience,
so,
but it is like what's going to
Yeah.
be the reentry
Yeah.
group, right? So, and just thinking about different family
Yeah.
engagement strategies, and I know how hard the community providers are working to engage the families.
Yeah,
on the outside, too,
absolutely.
and
I mean, it's
so
something
tough.
we've thought about and
So
have
it's
wanted to
something to
move
think about.
towards. Absolutely. And I mean, you see even when the parents come to the units for visiting, how they kind of make their own little networks too.
Right.
Even they're
Right.
like, you know, they're walking
Because
out
they
the
feel
door
so
and they,
isolated.
and
They
they're-
feel just as mistrustful.
Mhm.
They feel just as stigmatized. They feel
Right.
just as like, what am I going to do?
And it's a hard system to navigate.
Absolutely.
You know, it's a really hard system to
Yeah.
navigate. And so it's like peer support. Hey, you've been through it. What happened when your son went through this? Hey, you know, so they do kind of naturally, reach out to each other. And it's absolutely, it's a great idea and something.
It worked.
Definitely.
Yeah, for a little.
Absolutely.
I'm wondering if you could speak to what the burnout rate and turnover rate is for your behavioral health staff.
Yeah.
Like throughout your whole presentation, I was just like, wow, that seems so hard. It seems so difficult.
Yeah, I mean, I've been there 10 years, and I don't know if burnout is something.
I think it's a lot less hard than you would think. One thing that the medical director who was here before I was told me coming in was, it's not like when you're a child psychiatrist sitting in your outpatient office and the kid would rather be skateboarding or something. When you come and bring a kid out of their room, that may be the highlight of their day. So they do react to us differently in that way. I think the other piece is having a really great team that work well together and support each other so that no one person feels burned out.
Yeah, I mean, I think it's, I think that, this probably isn't a good thing, you get kind of like desensitized to it a little bit, but I think it's like how you are able to come back and do the work, and, it's like trying to hold on to that, because I think there's times where, like, you unfortunately lose so many kids, right, over the years to community violence, and it starts to kind of, you lose like another kid, not that you don't have compassion, but I think it's like finding that balance. And again, I think we have a pretty strong, solid, supportive team, and we all support each other. A lot of checking in, a lot of humor, a lot of laughing, a lot of probably doesn't always sound like the most strength-based talk around our kids and who we're working with, but I think it's just like our own coping and way to manage it.
It's also a very hopeful population. I mean, I have to say, the other thing is that, we do see kids getting structure that they haven't had before, services they haven't had before, and we have a lot of graduations from high school right on site, and they do them individually, which seemed very odd to me at first, but I guess they have to do it that way because you never know how long a kid will be in, and when they've got enough credits, then they hold a graduation. It's really been so nice to see those where family members come, and all of the teachers who are on site, which is like 40 people, will show up, and clinicians working with the kids. So there are a lot of reasons like that keep it going.
And the youth are really, they're very gracious. They very much appreciate the support. They, they recognize that we're like their ally and that we're there to help them. I think maybe not initially sometimes, or depending on the day, but they really appreciate it, and have often not had someone like just stop and check in and say, how are you doing? How's your day? And so they're a very they want the support, and so I think that makes it kind of easier too sometimes.
Yeah, even among the parents, they vary. I mean, I hesitate to say one group is more resistant than another. I think as in child psychiatry, we learn to expect a lot of resistance, and it's it's sort of a lifetime of education and understanding and working around resistance. And yeah, people come in with suspicions, maybe some in more communities than others, but parents often feel like, you know, oh, this is the first person that's understood or is listening to me and wants to help my kid. And so it's very powerful.
So what I think may already be a part of your work or what's going on at Youth Guidance today, restorative justice, you haven't commented on that. And I think that's often empowering and of course can shape behavior in positive ways. So I don't know if that is already a part of the treatment model or how you could collaborate with.
Yeah, I mean, again, not in custody necessarily, but there are, you know, depending on kind of the youth's disposition and what probation and the courts determine, there are programs in the community that are doing that.
I'm curious about, oh, go ahead. Go ahead.
I'm curious about mindfulness because I've seen it work with some adolescents I've worked with, and I don't know what the evidence base is in the incarcerated population, but has that been something you guys have tried or thought about?
Yeah, we tried the mindfulness group with the kids. It did not go over so well. It was hard to get them to do that. I have found it effective kind of more individually. And again, like, you know, some of, when you're working on an outpatient basis, like some of the resources the kids have that help them, right? Music, this, that, they don't have that, you know, so all they have is their mind. And so, you know, when we're trying to think of kind of interventions and strategies to manage different things, that's where it can be really helpful. Because, you know, when you ask them, like, what are your coping strategies? Music, weed. Okay, well, you're not going to get any of that in your room, so let's like think outside the box. And so in terms of a group, it didn't go over so well. I think a lot of that is just, you know, like you put, you know, 10 adolescent boys in a room and there's like this little bit of like, you know, social, you know, stigma, and even though they'll do it individually with their therapist, talking about it in a group is a little bit more challenging. But yeah, it definitely has been effective, and it's like, you know, it's kind of one of the few coping skills they can utilize while they're there because they don't have access to everything while they're sitting in their room. So
They do, however, like the yoga programs.
Yeah.
We have community providers who bring
Yes.
in yoga a few times a week on each unit, and that gets a high turnout. The kids really seem to enjoy it, and some continue practicing inside of their rooms. You can see that going on. So
Both different genders
Mhm.
that appreciate the yoga.
yeah, yeah.
You probably have heard about San Quentin has a mindfulness program that a man named Jacques Verdun has initiated, but years and years and years ago. So perhaps they could be a consultant somehow, since they have engaged adults
Yeah.
with that program. And several actually came to Spirit Rock. So there were people from San Quentin that actually spoke about the program after leaving San Quentin.
Great research, thank you.
When I was at the juvenile court in the 1970s and Ron Lewis was there in the 1990s, we spent most of our time doing evaluations for the court and sometimes testifying in court and writing reports that were, this was a much more forensic-oriented program. I think there are some advantages to having an identifiable separate mental health clinic to get a certain amount of credibility and trust built up. But who does the forensic work at the juvenile court now?
We have a panel called the Alienness Panel of clinical psychologists that are outside contractors that the referrals go to.
Right.
And so as SPY, we have stepped out of that role because really we want our only role and intent to be there to support the youth while they're in custody and kind of get them what they need, and to not be in a position of you know, making forensic recommendations about them. So we have a panel of psychologists that do all the our clinical psychologist oversees the panel.
Right.
But they, you know, they're independent contractors that are assigned the evaluations and will come in and meet with the youth and work with the families.
But you also mentioned the vulnerability sometimes of the court subpoenaing the medical records, and then you have to walk that tightrope.
Yeah. Yeah, and even though we make it very clear that that's not our role, imagine, you know, in the court system, we try to listen.
One of the issues in juvenile court in the last decade has been the increased requests for juvenile competency evaluations. And this becomes hotly contested because the defense attorneys want their clients to be found incompetent, because then they're released, because there are no treatment facilities for incompetent adolescents by and large. And then, of course, the kids understand that if they're found incompetent, they get released, and there's no consequence to what happens to them or other members of their gang. How is this issue of competence dealt with in your mental health setting?
Yeah, so we actually have a competency attainment program that is a DPH program. So youth that are found incompetent are they go through that curriculum. There's like a standardized curriculum that they go through, and then they will be reassessed to see if the competency has been restored.
Right.
And so there is a program to like address that. So it's not that you're found incompetent and you get to go home.
Okay, so this is relatively unique, unusual.
I think some of the we adopted the program from Santa Clara County.
Right.
Because we did see this influx of suddenly like everybody's incompetent.
Right.
But it actually wasn't working in the benefit of getting the kid released. It was actually getting them stuck in the juvenile justice system longer because,
they weren't able to be adjudicated and placed in a program.
Right, so they were just sitting there.
Right,
So it actually was not working kind of the way that it used to work.
Exactly.
And so because of that too, we've seen a lot less, declarations of doubt, where for a while it was like everybody.
The reason I'm so curious and sensitive about this issue is that in our forensic program here at UCSF, our forensic fellowship, we have a contract with the San Mateo County Juvenile Division to do juvenile competency examinations by contract with their detainees or whoever is requested. And so we get involved in this issue all the time about if they are incompetent, what happens to them, what programs are. So I'm very curious about how successful you think this can be done within a measurable period of time.
Yeah, competencies in terms of the courts, right, it's like, can they assist their attorney?
Do they understand the nature and the quality of the accusations, and can they assist their counsel?
Yeah, so in that sense, it's relatively successful, right? It's working with the kid, they do a great job, the clinicians doing that. They have pictures of the courtroom, they have flashcards. So I think that most of the time, they're successful in restoring competency for the legal part of it. I think that there's always that concern that there's other, there's other cognitive issues or concerns, or how we, like in the mental health world, might think of competency versus like how the legal world sees it.
My other question is, how do you work with the substance abuse problems that are rampant in this age group?
Well, they're, for the most part, clean and sober when they're in custody. They're cured. They're cured.
It's a great thing.
When they're in custody. But again, we have a lot of probation programs, community-based programs that are working on that. I think, when they're in custody, that resolves the problem. So it's an ongoing, I think, challenge, though.
Aren't they subject to random?
Excuse me, we're gonna have to stop. We have another class coming. So, thank you very much.